Once you have the reticulocyte, it enters circulation, becomes a red blood cell within a day or two. It's going to go through some more changes, and the shape is going to change. And again, we're going to get rid of some of those things we don't need, like ribosomes. In all, to go from hemocytoblast to reticulocyte, about 2 weeks. Reticulocytes account for only 1 to 2% of the red blood cells in circulation. Right? They're not technically a red blood cell yet, but that's what they're on their way to becoming. And looking at the percentage of reticulocytes in circulation can be used to gauge the rate of erythropoiesis. So if the percentage of reticulocytes is going up, what's going on with erythropoiesis? It's increasing. And why would erythropoiesis need to increase? Because maybe tissues aren't getting enough oxygen. So we need more red blood cells, so we have more hemoglobin to carry more oxygen to deliver to those tissues. Well, one tissue in particular, one organ, the kidneys, have cells that are very sensitive to changes in oxygen delivery and respond by secreting more or less of a particular hormone. And that is EPO, erythropoietin. So when oxygen delivery goes down and these cells are receiving less oxygen, they respond by releasing more EPO. EPO gets into the bloodstream, targets red bone marrow. Right, so we start with low oxygen delivery to the kidneys. They secrete EPO, gets in the blood, targets the red bone marrow, and basically ramps up the rate of erythropoiesis. Now to do that, you're going to have to stimulate some specific cells in that pathway. What would be a good cell to stimulate to speed up the process of erythropoiesis? The committed cell. And it's not the only one. So EPO is stimulating the proerythroblast. And also a progenitor cell. So in turn, if you increase the rate at which myeloid stem cells give rise to proerythroblasts, then you have a domino effect. Well, then you're going through myeloid stem cells faster. So the hemocytoblasts are going to have to pick up the pace. They're going to have to differentiate faster to form more myeloid stem cells, to form more progenitor, and thus proerythroblasts. Does that make sense? So hemocytoblasts can just divide. You're not going to lose this stem cell population. You're not going to run out of these cells. It's just a question of how quickly are they dividing and differentiating into these committed cells. And we're trying to speed up that process. So we have other chemical signals to ramp up the other pathways if we need to make other blood cells, like monocytes or lymphocytes or even platelets. So EPO is specific to red blood cells. What could cause decreased oxygen delivery to the kidneys? Or in other words, what could, let's start there. What could cause decreased oxygen delivery to the kidneys?
Not enough oxygen in the atmosphere.
Anemia, which is insufficient oxygen carrying capacity. We're not carrying enough oxygen in the blood.
Or the shape. Because the shape.
And usually, what do you think of with anemia? Why aren't we carrying enough oxygen in the blood?
Doesn't buy.
Maybe not enough red blood cells, which you need iron to make. Maybe the hemoglobin isn't just deficient but abnormal, maybe from a genetic mutation. But let's say red blood cell count is fine, hemoglobin concentration is fine. What else could cause lack or decreased delivery of oxygen to the kidneys? Blood loss,
Carbon monoxide.
which doesn't change your ratios, right? You have less total blood, but still have the right hematocrit and hemoglobin concentration. Right.
All blood
Yeah, gas exchange is being impaired by any number of pulmonary disorders. High altitude. Everything could be perfectly fine in your body, but at high altitude, per volume of air, per liter of air, there are fewer oxygen molecules. Right? The pressure is lower up there, so the gases are more spread out. So decreased concentration of oxygen per liter of air. So every time you take a breath in, even though it's the same size breath you would take at sea level, there's less oxygen molecules in that inhalation. So less oxygen going into the blood. What else? Let's say no pulmonary issues, not at altitude, no anemia.
Carbon monoxide in the air.
So what might cause lack of pressure specific to the kidneys? And I'm thinking more of an anatomical issue. Maybe there's a tumor putting pressure on the renal arteries. And so there's just less blood flowing into the kidneys, and that's why oxygen delivery has gone down. So there's any number of possibilities. Lots and lots of reasons. The goal of hormonal regulation of erythropoiesis, the goal of EPO, really to keep the hematocrit stable. But should we experience a pulmonary disorder or high altitude, we need to be able to adapt. So there are times when we do need more EPO and more red blood cells. If you look at someone's hematocrit who lives at 10,000 feet elevation, what does it look like compared to someone who lives at sea level?
Much higher.
It's a lot higher. To compensate for the reduced concentration of oxygen in the air, right, per volume of air.
Does the opposite happen for people who live in high altitudes when they come to lower altitudes?
They acclimatize just like we do when we go up there, but now the opposite for them. Their kidneys are receiving more than adequate oxygen delivery. EPO secretion goes down, erythropoiesis goes down, and the red blood cell count goes down until you're at a typical hematocrit for someone who lives at sea level.
How fast does that happen?
Does that make sense?
Does it hurt, or you does it prevent
No, no. Now it takes time, so the cool thing is you can go spend some time at high altitude, even train at high altitude, and that increased hematocrit, you'll get to take advantage of that for at least a few days when you come back to sea level.
How come your hematopoietic levels are lower when you're in a higher altitude, when there's less oxygen?
EPO,
I mean, your EPO.
it's higher at high altitude
But why?
because you need more red blood cells. Oh, why do you need more red blood cells?
Yeah.
Right, per volume of air, there's less oxygen available. See, everyone thinks it's the percentage of oxygen that has changed at high altitude. It's still 21% at high altitude. It's 21% at sea level. But you have to remember those gas molecules are more tightly packed at a higher pressure. So per liter of air, there's more gas molecules, but at high elevation, they're spread out. There's less pressure. So it's really the quantity per volume of air, and that's the issue. So it's still 21%. That hasn't changed.
Does that mean they're binding less oxygen? Is that what they're more cells?
Binding,
Like,
because there's less oxygen available, there is less binding, there is less carrying, but one way to compensate for that is just to make more hemoglobin available. So even though each hemoglobin probably isn't going to carry 4 oxygen anymore, maybe 3, 2, at least you have more carrying 2 or 3, right? That was just like our discussion with hormones. If you have a lower than normal hormone concentration, what can a target cell do to increase its response to that low concentration of hormones? Upregulate. And as long as you have more receptors, even though you haven't changed the amount of hormone, you still get more interaction. So same exact thing by making more hemoglobin available. Now, of course, once we figured out that EPO stimulated erythropoiesis, we started using synthetic EPO for increased athletic performance, called blood doping. That's one version of blood doping. The other version, what we used to do before synthetic EPO was readily available, take some blood out, right? And then wait a week or two, and your body will replace that blood, and then put the blood back in, and probably just the cells, because that's all you really care about, not the plasma, and artificially increase your hematocrit by injecting your own red blood cells back into your body. But really no need for that anymore, because now you can just take synthetic EPO and increase your hematocrit that way.
So when athletes do the whole blood doping with the synthetic way, they can get caught. What if you do it the way that they did it before, where they take out their own blood and then replace it back?
I would imagine that they're probably getting a baseline of your hematocrit, and then they could, if they do a blood draw, they could see that it has suddenly increased,
Okay.
and you would, I'm sure, would still be penalized the same way, I would assume.
Okay.
What if they take the Epogen, which is the synthetic
The synthetic.
one, and wouldn't it still increase kind of gradually?
Well, it depends on how much you take.
Yeah.
Sure. Yeah. Yeah, if you only do it a little bit, yeah, it's going to be hardly noticeable, right? You could have just gone up to Tahoe for a few days and seen the same result. Why is it banned? Why is it so dangerous? It doesn't cause blood to clot, but you just now have too many of those cells inside of these really small capillaries, and they can start to clog it up, just the sheer number, right? And so that can cause stroke and heart attack and kidney damage. And then what was the other problem?
It's harder for the heart to pump.
This viscosity goes up. So you're asking the heart to pump syrup through vessels instead of water.
Would cause the pH applied to more basic?
Okay.
Who should be taking synthetic EPO?
Anemic.
Kidney patients.
Right, because there's lots of possibilities, but what's a really common one?
Kidney disease.
Yeah, kidney disease.
Cancer treatment,
Really?
radiation, chemo. What's happening to all highly mitotic cells in the body, not just the cancer cells? They're all being affected. And the rate of cell division is reduced. So you're still turning over red blood cells at a normal rate, right? They're still breaking down after 3 months, but the rate of production has gone down. So it brings your hematocrit down. And that's one reason that individuals on these medications often have fatigue and literally anemia. So that's exactly who we give it to most commonly. It's cancer patients who are in the middle of treatment. And we can do the same for their white blood cells, right? There are other chemicals called colony-stimulating factors that we can give them to do the same thing, get their white blood cell count up. And platelets, because all are affected, right? All those cells come from stem cells in the red bone marrow. What other tissue in particular is affected by chemotherapy, radiation? It's why we have hair loss. It's why we get nausea. The stomach intestines are so delicate.
Epithelial.
Epithelial tissue has a really high turnover rate. Right? So that's reduced as well. So hair keeps coming out at the normal rate, but it's not being replaced at the normal rate. Because we all shed hair all the time. All right, break. Let's say...